Managing optic pit. Know your stuff. Our regular ILM flap technique did not prove sufficiently successful in treating optic disc pit maculopathy. The preliminary results of our modified technique, ILM stuffing, were recently published. Lasering creates a barrier against fluid migration to outer retinal layers. ILM peeling is performed to decrease the possibility of fluid migration to the inner retinal layers. The ILM is introduced into the optic pit to stuff it. You see the surgical technique with simultaneous horizontal and vertical intraoperative OCT B-scan. We present the results in two different morphological appearances. First, in cases of retinal detachment. Second, in cases of intraretinal fluid accumulation with and without outer lamellar macular hole. Our first case, a 15-year-old girl, was operated in another department without success 18 months earlier. You see retinal detachment in the course of morning glory syndrome with optic pit. During primary surgery, ILM peeling in the macular area was performed. An ILM flap was formed in the lower part of the macula and stuffed into the optic pit. Laser spots were applied above and below the fovea, which was located at the boundary of the optic disc. Fluid-air exchange followed. Complete retinal reattachment was noted at the first post-op follow-up at 1 week and persisted to the end of the follow-up period of 2.5 years. Almost normal OCT angiography persisted during follow-up. Next, a 25-year-old woman was initially healed for 3 years after ILM flap was located on top of the optic disc. After 3 years, recurrence of central retinal detachment was observed. During subsequent surgery, ILM was found back in its original position on the retina, peeled once again, and, this time, stuffed into the optic pit. Immediate healing of retinal detachment was observed after 1 week and persisted for 3 years of follow-up. A 60-year-old woman with retinoschisis in the course of optic pit is operated. Trypan blue staining shows the path of fluid migration into the retina. An ILM flap is formed and stuffed into the optic pit. Intraretinal fluid disappeared after 1 year. Next, a 38-year-old woman with intraretinal fluid and outer lamellar macular hole in the course of optic pit maculopathy is operated. Posterior hyaloid detachment is performed. ILM is peeled in the area close to the optic nerve to create a flap, which is stuffed into the optic pit. Almost complete regeneration of the macular structure took 1.5 years. a small central photoreceptor defect persists. A 14-year-old girl is operated for an extremely large outer lamellar macular hole in the course of optic disc pit maculopathy. ILM is peeled between the optic nerve and fovea to form a flap and introduced into the optic pit. Laser treatment is performed at the temporal side of the optic nerve. Even after 2.5 years, a small defect in the photoreceptor layer is detectable. OCT angiography shows an almost normal superficial vascular plexus during follow-up. Deep vascular plexus is initially difficult to recognize because of segmentation artifacts, but slowly shows normalization. We observe flow changes in choriocapillaris. Conclusions. Stuffing the optic pit with ILM may be an important step in the treatment of optic pit maculopathy. In cases where retinal detachment is a dominant clinical feature, healing may be achieved in the early postoperative period. In cases of intraretinal changes with or without outer lamellar macular hole, healing takes many months, and the healing process shows abnormalities in the deep vascular plexus and choriocapillaris in OCT angiography.